So welcome to the Home Health Virtual Training Program, Part 1. My name is Charlotte Stininger, and I'm presenting Section D, Patient Mood Interview and Total Severity Score. I'm a registered nurse with experience in acute and post-acute care, direct care, nursing, education, and quality management, specifically in the home health setting. And currently, I'm a senior staff associate at Econometrica Incorporated in Bethesda, Maryland. At the conclusion of this training, you should be able to describe D0150 patient mood interview, the PHQ 2 to 9, and D0160 total severity score. Identify the intent, coding instructions, and interviewing tips for the Patient Health Questionnaire, known as the PHQ 2 to 9, and D0160, the total severity score. Now, this is a new section in the OASIS, and it contains items related to the assessment and coding of mood distress for home health patients. Those items include D0150, the patient mood interview, D0160, the total severity score, and D0700, social isolation. Note, though Section D includes D0700, the training for this item is contained within the social determinants of health presentation. So we'll start with D0150, patient mood interview. D0150 patient mood interview is comprised of the PHQ-2, and along with remaining 7 items make up the PHQ-9. This item is completed at start of care, resumption of care, and at discharge. The intent for D0150 is to identify the presence of signs and symptoms of mood distress, a serious condition that is underdiagnosed and undertreated in home health and is associated with significant morbidity. It is particularly important to identify signs and symptoms of mood distress among home health patients because these signs and symptoms can be treated. Now, the rationale for this is described in the guidance. Depression can be associated with psychological and physical distress, decreased participation in therapy and activities, decreased functional status, and poorer outcomes. Mood disorders are common in home health, and as I said, are often underdiagnosed and undertreated. We begin with defining the PHQ 2 to 9, known as the Patient Health Questionnaire. This is a validated interview that screens for symptoms of depression. It provides a standardized severity score and a rating for evidence of a depressive disorder. To start, it's important to note that if start of care, resumption of care assessment is completed, you want to complete it as close to the time of the start of care, resumption of care as possible. If a discharge assessment, complete as close to the time of the discharge as possible. The response-specific instructions provide you guidance for how to approach this interview. You'll want to conduct the interview in a private setting if possible. Interact with the patient using their preferred language. If the patient appears unable to communicate, offer alternatives such as writing, pointing, sign language, or cue cards. If an interpreter is used during the patient interviews, the interpreter should not attempt to determine the intent behind what is being translated, the outcome of the interview, or the meaning or significance of the patient's responses. It's important to explain the reason for the interview before beginning. The guidance provides some suggested language, such as, I'm going to ask you some questions about your mood and feelings over the past 2 weeks. I will also ask you about some common problems that are known to go along with feeling down. Some of the questions may seem personal, but everyone is asked to answer them. This will help us provide you with better care. A cue card with response choices clearly written in large print may help the patient comprehend the actual response choices. It's important to explain and or show the interview response choices, and the OASIS guidance provides some suggested language here. I'm going to ask you how often you've been bothered by a particular problem over the past 2 weeks, and I will give you the choices that you see here on this card. And then you will show the patient the cue card and describe the response options by saying, your response choices are 0 to 1 day, never or 1 day, 2 to 6 days, several days, 7 to 11 days, half or more of the days, or 12 to 14 days, nearly every day. So we start by asking the first 2 questions, D0150A and D0150B, of the patient mood interview. Now the question we ask regarding those two items is the following. Over the last 2 weeks, have you been bothered by any of the following problems? And then list the problems or symptoms that are included in D0150A. Now, this question is about determining if the patient is bothered by the symptom. This is not our interpretation or perception of the symptom presence, meaning that we don't score this item based on our assessment or determination if the patient has these symptoms. This should all be based on patient report. And we will cover the coding instructions for these response choices a little later in the presentation. Now remember, for each of the questions, read the item as it is written. Do not provide definitions because the meaning must be based on the patient's interpretation. For example, the patient defines for themselves what feeling down means, and the item should be scored based on the patient's interpretation. Each question must be asked in sequence to assess presence, column 1, and frequency, column 2, before proceeding to the next question. Enter code 9 if the patient was unable or chose not to complete the interview or responded nonsensically. A nonsensical response is one that is unrelated, incomprehensible, or incoherent, or if the patient's response is not informative with respect to the item being rated. For example, when asked the question about poor appetite or overeating, the patient answers, "I always win at poker." Let's look at the coding instructions for column 1 symptom presence. Code 0 no if the patient indicates that the symptoms listed are not present. Enter 0 in column 2 as well. Code 1 yes if the patient indicates that the symptom listed is present, then you would enter a 0, 1, 2, or 3 in column 2 symptom frequency. Code 9 no response if the patient was unable or chose not to complete the interview and or responded nonsensically. Then you would leave column 2 symptom frequency blank. Now, a dash is also a valid response for column 1 only. If you were to use a dash, then you would leave column 2 symptom frequency blank. So you can see in these coding instructions how this coding of symptom presence can define how symptom frequency is coded as well. So for coding symptom frequency, code 0 never or one day if the patient indicates that during the past 2 weeks they have never been bothered by the symptom or have been bothered by the symptom on one day. Code 1 2 to 6 days, several days, if the patient indicates that during the past 2 weeks they've been bothered by the symptom for 2 to 6 days. Code 2 7 to 11 days, half or more of the days, if the patient indicates that during the past 2 weeks they've been bothered by the symptom for 7 to 11 days. Code 3 12 to 14 days, nearly every day, if the patient indicates that during the past 2 weeks they've been bothered by the symptom for 12 to 14 days. It's important to determine if the patient is rarely, never understood verbally, in writing, or using another method. If the patient is rarely, never understood, you would code D0150 A1 and B1 as 9, no response. Leave D0150 A2 and B2 blank in the PHQ interview and skip D0160 total severity score. So let's consider. If D0150 column 1 symptom presence is yes, ask the patient to tell you how often they were bothered by the symptom over the last 2 weeks. Use the response choices in D0150 column 2 symptom frequency. Start by asking the patient the number of days they were bothered by the symptom and read and show the cue card with frequency categories and descriptions. Once you have scored the first 2 items of the patient mood interview, it's important to determine whether to complete the PHQ-9, meaning ask the remaining 7 questions, D0150C through D0150I. Whether or not further evaluation of a patient's mood is needed depends on the patient's responses to the PHQ-2, D0150A, and D0150B. If both D0150A1 and B1 are coded 9, leave D0150A2 and B2 blank, then in the PHQ-2 and skip D0160 total severity score. If both D0150A2 and B2 are 0 or 1, then there's no need to continue the PHQ. You would end the PHQ-2 and enter the sum from D0150 A2 and B2 in D0160 total severity score. For all other scenarios, proceed to ask the remaining 7 questions, D0150C through D0150I of the PHQ-9. Then complete D0160 total severity score. Now, that's a lot of ifs and ands, so let's break this down a little bit more visually to help clarify. Let's think about a scenario where the patient is rarely never understood, and the symptom presence for the first 2 items is coded with a 9, and the symptom frequency is left blank. So if both D0150 A2 and B2 are blank, then there's no need to continue the PHQ-9. In the PHQ-2 patient mood interview, and leave D0160 total severity score blank. Now let's think about a scenario where both symptom frequencies for the first 2 items are coded as a 0 or a 1. So if both D0150 A2 and D0150 B2 are scored with a 0 or a 1, then there is no need to continue the PHQ-9. You'll end the PHQ-2 patient mood interview and enter the total score from D0150 A2 and B2 in D0160 total severity score. Excuse me. There are a few other scenarios for when you would complete the remaining 7 questions and complete D0160 total severity score. So if D0150 A2 and B2 are both scored as a 2 or a 3, or if either are scored as a 2 or a 3 and the other is scored with a 1 or a 0, then you would ask the remaining questions and complete D0160 total severity score. Now, it's important to attempt to conduct the interview with all patients. For question D0150I, thoughts that you would be better off dead or hurting yourself in some way. Experienced interviewers have found that most patients who are having these feelings appreciate the opportunity to express it. Asking about thoughts of self-harm do not give the patient the idea. It does let the provider better understand what the patient is already feeling. Best interviewing approach is to ask the question openly and without hesitation. Patients may respond to questions verbally by pointing to their answers on a cue card or by writing out their answers. If the patient uses their own words to describe a symptom, this should be briefly explored. If you determine that the patient is reporting the intended symptom but using their own words, ask the patient to tell you how often they were bothered by that symptom. It's important to remember that you select only 1 frequency response per item when coding the symptom frequency. If the patient has difficulty selecting between 2 frequency responses, code for the higher frequency. Some items, like item F, contain more than 1 phrase. If a patient gives a different frequency for different parts of a single item, select the highest frequency as the score for that item. Okay, let's review some interview tips and techniques. You can repeat a question if you think that it has been misunderstood or misinterpreted. Some patients may be eager to talk with you and will stray from the topic at hand. When a person strays, you should gently guide the conversation back to the topic. For example, say, "That's interesting, but now I need to know," or "Let's get back to," or "I understand, can you tell me about?" Sometimes it's important to validate your understanding of what the patient is saying by asking for clarification. You can say to the patient, "I think I hear you saying," or "Let's see if I understand you correctly," or "You said blank, is that right?" Now let's take a few minutes to learn about specific interview techniques that can be utilized to help a patient identify their symptom presence or frequency. Unfolding. Unfolding is a technique that can be used if the patient has difficulty selecting a frequency response. With unfolding, you offer a single frequency response and follow with a sequence of more specific questions. Now, this is an excellent technique for when your patient reports being bothered by a symptom, but can't seem to identify how often it has bothered them. Here's an example. Say to your patient, "Would you say feeling down, depressed, or hopeless has bothered you more than half the days in the past 2 weeks?" And if the patient says yes, then show the cue card and ask whether it bothered them nearly every day, 12 to 14 days, or on half or more of the days, 7 to 11 days. Now, if the patient says no, show the cue card and ask whether it bothered them several days, 2 to 6 days, or never or 1 day, 0 to 1 day. Next, there is probing. Sometimes patients may provide a non-committal response, such as not really, and this response should be explored. When probing, you respond to a non-committal response by gently encouraging the patient to tell you if the symptoms bothered them, even if it was only some of the time. Now remember, probing should be done by asking neutral, non-directive questions. And some examples of this technique include saying to the patient, "What do you mean?" Or "Tell me what you have in mind." Or tell me more about that. Or "Please be more specific," or "Give me an example." Sometimes patients may give you a long answer to an interview item. It's important to narrow the answer to the response choices available. Echoing is where you summarize longer answers to interview items by narrowing the answers to the response choices available, and then ask the patient which response option best applies. Here's a good example. For item D0150E, poor appetite or overeating, the patient responds, "My daughter's food is always cold and it just doesn't taste like it does at home. The doctors won't let me have any salt." The possible interview response would be, "You're telling me that the food is not what you eat at home and you cannot add salt. How often would you say that you were bothered by a poor appetite or overeating in the last 2 weeks?" If the patient has difficulty with longer items, you can separate them into shorter parts and provide a chance to respond after each part. This interviewing technique is called disentangling. This method is helpful if a patient has a moderate cognitive impairment but can respond to simple, direct questions. Here's an example. For item D0150E, poor appetite or overeating, you can simplify this item by asking, "In the past 2 weeks, how often have you been bothered by a poor appetite?" And then pause for a response, and then say, "Or overeating," and then pause for a response. Okay, now let's take a look at D0160 total severity score. D0160 total severity score identifies the severity score calculated from the responses to the PHQ 2 to 9 item D0150. This is completed at start of care, resumption of care, and at discharge. It's important to note D0160 total severity score does not diagnose a mood disorder or depression, but provides a standard score that can be communicated to the patient's physician, other clinicians, and mental health specialists for appropriate follow-up. The total severity score is a summary of the frequency scores on the PHQ 2 to 9 that indicates the extent of potential depression symptoms. And remember, do not add up the score while you're interviewing the patient. You should focus your full attention on the interview. Use the scoring guide. There is a scoring rules section in the section D part of the OASIS-E manual that identifies the patient mood interview total severity score D0160. And you can use that to help complete the scoring. And note, the maximum score for D0160 is 27. The total severity score will be between 00 and 27, or 99 if the symptom frequency is blank for 3 or more items. And as a reminder, the total severity score is left blank if only the PHQ-2 is completed because both D0150A1 and B1 were coded 9. And remember, when you do that, you would leave D0150A2 and B2 blank in the PHQ-2 and leave D0160, the total severity score, blank. If no assessment is conducted for symptom presence, you'll enter a dash in column 1, skip column 2 for each row D0150 A through I, and then code 99 for D0160 total severity score. Hopefully this illustration will help in understanding this concept of when only the first 2 items are scored with a 1 or a 0 for symptom frequency. Again, in this case, you would not complete the remaining 7 questions. You would add the numeric scores from these 2 frequency items and enter that value in D0160. With the goal of reinforcing these concepts, this illustration depicts a scenario where all symptom frequencies for the 9 items were scored. So in this case, you would add those numeric scores from D0150A2 through D0150I2, following the instructions found in the scoring rules in section D, and then enter that score in D0160. Here's an illustration of another scenario, one in which the symptom frequency was blank for 3 of the items. In this case, the interview is deemed not complete, and you would enter a 99 in the total severity score. Now remember, response to the PHQ 2-9 can indicate possible depression if the full PHQ 2-9 is completed. Responses can be interpreted as follows. Major depressive syndrome is suggested if of the 9 items, 5 or more are identified at a frequency of half or more of the days, 7 to 11 days, during the look-back period. Minor depressive syndrome is suggested if of the 9 items, the following are identified at a frequency of half or more of the days, 7 to 11 days, during the look-back period. And those items are D0150B, feeling down, depressed, or hopeless, D0150C, trouble falling or staying asleep or sleeping too much, or D0150D, feeling tired or having little energy. In addition, the PHQ 2-9 total severity score can be used to track severity over time. Total severity scores can be interpreted as follows. 0 to 4, minimal depression. 5 to 9, mild depression. 10 to 14, moderate depression. 15 to 19, moderately severe depression. And 20 to 27, severe depression. Additional scoring rules for D0160 can be found in the OASIS-E guidance manual. These rules apply if D0150C through D0150I were asked and describes the following. Descriptions on why column 2 symptom frequency could be left blank, how to compute the total severity score with considerations for the number of missed items in column 2 symptom frequency, and also examples of scoring the total severity score based on the number of missing values in column 2 symptom frequency. And so we invite you to review that guidance for specific instructions regarding these scenarios. In summary, D0150 patient mood interview, the PHQ 2-9, is a standardized assessment for depression and mood disorders. Following the response-specific and coding instructions for the PHQ 2-9 is essential for accurate detection of possible depression. By tallying the PHQ 2-9 symptom frequency scores, a total severity score can be calculated. D0160 total severity score can help clinicians detect possible depression and the extent of depressive symptoms. We do welcome questions, and if you would like to submit a question regarding this presentation, please send it to pactraining@econometricainc.com by August 31st. We will be providing a live virtual training event in September, and select questions will be answered in a Q&A session during that training event. Thank you for reviewing, and we look forward to sharing more insights in the workshop training.